Welcome to CPF Firewire, a podcast from California professional firefighters where we discuss a wide range of issues affecting firefighters, our unions, our families, and the communities we serve.
Today on the Firewire, I'm pleased to welcome Dr. Katherine Warburton, who is a medical director at the California Department of State Hospitals and is a critical leader in the implementation of Community Assistance, Recovery, and Empowerment Act, also referred to as a CARE Act or CARE Court. CPF members see the impact on those experiencing severe behavioral health challenges each and every day. I know that I could walk into any fire station across the state and the firefighters on duty could name 5 to 10 people who are struggling and often rely on the 911 system, but don't get connected to the help that they really need. That's why CPF is one of the many organizations who supported the CARE Act, a critical policy that helps those with the most complex behavioral health conditions get access to the support that they need, including behavioral health services, housing, and support. Dr. Warburton, thank you for joining us on the Firewire today.
It's an honor to be here. Thank you.
I wanted to talk about, the CARE Act has been piloted in 8 counties. Initially, it was CARE Court. CPF, we were a very early supporter of this with Governor Newsom, and now it is preparing to go live in all counties in California here in December, I believe. And so what I wanted to talk about, Kate, with you as the medical director for California State Hospitals, we see what we see in the street. I want to talk about that, but I also want to talk about what you see coming into your hospitals, and then how it's going to be so important that we communicate and work together, and how the vision of the CARE Act can break the cycle of not only mental health emergencies for people, but potentially the cycle of homelessness. And I talk a lot, but tell me a little bit about yourself. Talk, how did you get into this field, and what do you see as really important things as we move forward in the CARE Act?
Well, thank you. And I think kind of my journey to where I am today illustrates part of the need for the CARE Act. I wanted to become a psychiatrist because I love working with people who have schizophrenia, which is a very specific diagnosis. And when I was in my junior year of training, I went to a lecture about community psychiatry and was informed about this issue on the criminalization of mental illness, specifically schizophrenia, and was shown data at that time. This is 1994. Shown data at that time illustrating that people with schizophrenia were largely being locked up in jails and prisons, and was advised to go do a forensic fellowship so that I would have the qualified training to work in those environments. And I came out here to California to do my forensic fellowship at UC Davis and started working at Napa State Hospital. And the data have only gotten worse over the last 20 years. So the state hospital system, we have 7,000 beds, and the vast majority of the patients in those beds are people who are living with schizophrenia, who've been arrested on a felony charge. And we've been researching this population with UC Davis researchers for the last 14 years. And we can tell you from our research that essentially what's happening is people who are living with schizophrenia are coming to us after being unsheltered and untreated. Mm-hmm. And the criminal justice contact that they're experiencing is a result of those conditions. And so after doing years of research as to what's happening with this population, I would say that the CARE Act is the first time in my lifetime, the most significant mental health reform in my lifetime, that has the potential to disrupt what's happening. One other important thing to point out is I described to you the problem in our hospitals, which is individuals with schizophrenia who are unsheltered and untreated being arrested, but the problem's getting worse. Our referrals increase 10 to 20% a year every year. So more and more people are falling into this downward drift and this cycle.
Like, would those referrals kind of generate from family? Like as a first step, or do you see them as more like referrals off the street and through the system, whether it's criminal justice or the EMS system?
Referrals into care?
Yeah. Yes.
Well, what we're seeing right now is it's largely families
Okay.
filing the petitions, and that's what I'm doing here. First responders are definitely qualified petitioners, and I would hazard a guess that that your constituency is experiencing the same kind of frustration that I am, just from a different vantage point.
So there's a couple things here that you just brought something to me that I hadn't thought of, and it's super important. When firefighters, when I was an engine captain, and you get that call for a 5150, a person in distress, and we go and we'll find a myriad of things, but generally speaking, in lay terms and probably crude terms, you find someone who's acting crazy. It could be, they could be clothed, they could be unclothed, they could be in the middle of an intersection screaming into the wind. They could be sitting on a corner just babbling incoherently at anybody who is or who is not there. And for us in the first response world, we don't necessarily have a way to make a field diagnosis of schizophrenia. I mean, I hate to say it, but when we see people like that, we lump everybody into the same spot. And the nice and official way to put it is they're a 5150. When you talk about people with schizophrenia, are there certain telltale signs that we as firefighters, paramedics, whether it's public or private, that we should be aware of? And the one that you brought up, and I had never thought about it, is when we go to people's homes and this kind of behavior is just starting to manifest. What do we need to watch for?
Well, the behaviors that you're describing are classic behaviors that people who are living with schizophrenia manifest. We have a tremendous amount of science now. We understand this disease pretty well, and we know that this is a biologically driven condition. It's a brain disease. It's not a behavioral problem or a problem with someone's values.
Brain disease meaning it's medical.
It's a medical condition,
Okay.
just like any other medical condition, but it impacts the part of the brain that perceives things. Okay, so what you've described when someone is talking to someone who's not there, that is a person who's having what's called hallucination. So they are literally hearing a voice.
Somebody's conversing with them.
Somebody's conversing with them because it has to do with how their brain perceives and interprets stimuli. And so people who have hallucinations, especially something called command hallucinations, that's one of the drivers of unsheltered conditions as well as criminal justice contact. If someone has a voice that is ordering them or compelling them, forcing them to do something, sometimes that's how people end up running afoul of the law. If they have the other prominent symptom of schizophrenia is a delusion. So a hallucination is seeing or hearing things that aren't there. A delusion is believing something that's not true, but believing it with all of your heart. So a lot of what we see coming in post-felony arrest are people who have paranoid delusions or persecutory delusions where they believe people are out to get them. And so when you see someone who's screaming on a street corner, they're not screaming at us. They're screaming at the voices in their head in the context, oftentimes, of delusions, specifically paranoid delusions. And that's what's driving their behavior, is their brain's inability to correctly perceive stimuli. And so instead of those individuals ending up having those brain diseases treated, they're winding up in the criminal justice system post-arrest and coming into us in the state hospital system. So I would say that the most important thing for your first responders to do is document those behaviors. And then the physician who's doing the second part of the petition, which is the affidavit, can interpret what your first responders are documenting. As a psychiatrist, I know that if someone's screaming at someone who's not there, that's likely a hallucination. So documenting and communicating those behaviors across shifts, documenting and communicating those behaviors to the emergency room staff would be really critical things for your teams to do.
Our service has progressed greatly, and so report writing is going to be very, very important to us. And how we document that so that it can be communicated I'm hearing over multiple layers. Let's say that we have UC Davis in Sacramento, and so I'm an engine captain out in the county. We have that person. The most appropriate facility is to go to UC Davis, and I tell the medics, or maybe they're my medics at my station, let the receiving hospital know that we want to, what documentation do we need to do to enter this person into the CARE Act or CARE Court? And let's make sure that this person gets that first level of help. What does that look like on the ER and the treating physician side of the house? What happens?
Great question. So, I reiterate, document everything you see. If the patient is talking to themselves or agitated, write down what they're saying. Write down how many times you've been called for this person. Write down the circumstances that you're finding this person in. Are they disheveled? Do they appear to be emaciated? Are they eating out of a trash can? Is their encampment, disorganized? Those would be all important things to document. Now, first responders can be petitioners,
Yes.
and we have some trainings up that I'll send the links to your team on some of the nuts and bolts.
I'm going to stop right there because this is a good thing. We will make sure that we put those links because we film this also. So I'll make sure that those links go on this podcast so that firefighters across the state will have those.
And so as a first responder, a potential petitioner, your team can file the Care 100 petition form if they're so inclined, and that's not a particularly onerous form. So if your team feels that they are in the best position to do that, by all means do that. Another alternative, and if your team members are petitioners, they do have to attend the first hearing, at which time the county behavioral health director or their designee will take over the case. So there's one hearing potentially in terms of an obligation. But what I'm hearing from the field is that the vast majority of those hearings are conducted virtually. So it shouldn't be too disruptive for your...
It also sounds, it's pretty similar to, let's say that we have a contact that requires adult protective services or child protective services or an injury with Cal OSHA. Almost with every one of them, there's follow-up. In some cases, it may be a subpoena in person, but in many cases, it's over. In my day, it was over the telephone,
Right.
and now in today, it would be more a virtual.
Right.
So it isn't. I didn't want to use the term, and I shouldn't use the term, a burden, because we're talking about a human being and getting them help. It's entering and getting a person into the CARE Act or CARE Court is very similar to all the reporting that we do today. There's not
It's
really
not a
any
foreign
different.
concept. I see. I don't expect the hearing portion to be onerous for your team. Alternately, if you're taking someone into the UC Davis ER repeatedly, collaborating and partnering, coming up with a system in your local community on how you, the ER physicians, the hospital social worker, how you are all working together, perhaps to get that petition filed, maybe come up with a system for. I have no doubt that if I interviewed your constituents in the field, they would know exactly who these people are, and they see these people all the time. And so come up with a plan to target, the 10 people in your community who are constantly being shuttled from the jail to their encampment, from the encampment to the ER, and all the places that these individuals end up because of their untreated brain disease.
That's super important, and I just learned this, and I don't want to get lost because you said it, and I've been thinking about it since you said it the first time. Schizophrenia is a physical illness.
Yes.
It is a disease of the brain. It is not. It affects your mental health, but it's a treatable.
It's very
disease.
treatable, extremely treatable.
And because my members will identify with this, because when we talk about post-traumatic stress injury, and that's why we call it an injury, it's treatable.
Right.
And kind of, let's say we enter a person into the system and you're part of their care team on the medical end. What does that look like to us? Because when we drop a person off at the hospital, we're on to the next thing. And quite frankly, what helps us survive is to not get
Right.
not get into the details of what happens next.
Understood.
So what happens next?
Well, if care is implemented correctly, a number of things will happen. The individual has a lot of input and agency in terms of the plan that's developed. That individual can voluntarily enter into what's called a care agreement, where they determine the parameters of their plan, or the individual can have a rather than a voluntary care agreement, a court-ordered care plan. And that's a plan that's overseen by a civil court judge. It has nothing to do with criminal justice. It has everything to do with the judge making sure that the plan is implemented with accountability. So that piece of it's very important, because I think what happens now is, I hear this all the time. That person doesn't want treatment.
Mm-hmm.
They want to live outside. This is a choice that they're making. And in reality, it's not. 60% of individuals who are suffering from schizophrenia spectrum disorders have a condition. The fancy term for it is anosognosia, but it's a lack of insight, because they believe the delusions that they're experiencing. So if they believe that the mafia is out to get them, they're not thinking, I'm having a brain disease that's causing me to think this. They actually think the mafia is out to get them. And so it's very difficult to engage someone in treatment if they don't know that they're ill. Furthermore, schizophrenia is the only disease in medicine where someone who lacks medical decision-making capacity has the ability to refuse care. Any other condition, let's think about Alzheimer's disease.
Wow.
I'm sure your constituents get called for people suffering from dementia who are wandering in the street, who got lost, who don't know where they are. Individuals with Alzheimer's dementia oftentimes don't know that they have dementia. And when they start doing things that are not in their best interest, someone says, okay, we're going to put them on Aricept and put them in a memory center and do all these other things. But with schizophrenia, despite the fact that we know this is a biologically based brain disease where people lack insight, we say, oh, they have the right, they have a choice. They're making a choice, when in reality, they're not. They're being driven by their symptoms. So
Is that just something that's like societal, or is there a reason for that? Like a person can have that momentary time of clarity to refuse? I mean, why do we do that?
It's a really good question, and I'm a student of mental health policy history and global mental health policy. We're the only country that I know of that says somebody has to be extremely imminently dangerous before we'll provide them with care.
And then we arrest them.
Right. And then we arrest them, and then they end up, there's 7,000 people right now locked into California state hospitals post-felony arrest. So we're not really doing anything for people's liberty interest at the end of the day. I'm sure there's many more than that who are currently in our jails. And I know we have, I think it's 30,000 people with a mental health diagnosis in our prison system. So the liberty argument falls apart when you look at how many people right now with schizophrenia in California are locked up. But the point of the CARE Act, this is an important point. So the care plan should have 3 essential elements. It should have stabilizing medication, it should have wraparound mental health services, and it should have housing. And if it goes to the point of being a care plan, the civil court judge can make sure that all of those services are being delivered to that person, and hold the behavioral health provider accountable to make sure that all those elements are provided to that person.
Can you talk about, and I didn't mean to cut you off,
No,
but
it's okay.
you're making me think of these things. Can you talk about, we've piloted this in 8 counties for quite some time. Can you talk about some of the successes that you've seen? And from a person that may have been on a street, from early recognition,
Yes.
what are you seeing on your side of the fence that we would not ordinarily see? Because this is important.
Well, I think the individual stories are incredibly moving. And so when we have stakeholder meetings and so forth, we will hear about individual stories. One of the things that we're hearing is that these individuals are easier to engage than people thought. A lot of people are kind of, despite the fact that they're not totally oriented to consensual reality, are saying, okay, if you want to give me some help, I'll take some help. And so there's a lot of people who are being engaged, which is a really positive thing for me to see, since I see people when they've gotten to the worst possible point. And I think we're seeing people stabilizing because psychiatric medications, they work. They're as effective as any other medication for a chronic condition. So antipsychotic medication is as effective as cholesterol medication. It's as effective as antihypertensive medication. And so I think we're also seeing some myth busting around the fact that these are not treatable conditions, or that these are character deficits, or these are choices or flaws. And we're seeing a change in thinking in terms of the efficacy and how stable someone can become when they're no longer hearing things or believing things that aren't true.
What's kind of interesting here is that, as firefighters, sometimes we do a lot of repeat type calls, and we do repeat calls with the same people. And it can get frustrating because you don't think you're making a difference. And just this conversation here, I think it's going to be highly important that we publish regular after action reports and the differences that are being made. I mean, just for me, the awareness, I feel really ignorant. I didn't know schizophrenia was a brain disease. I'm sorry I'm hung up on that, but I didn't know that.
A lot of people don't.
And that's going to be an important piece of this. The other one is we're sitting here talking about it, and I know the Pasadena Fire Department has a mobile integrated health team that goes out into the community, I would say, to prevent medical or psychiatric crises and to intervene early. I believe Metro Fire here in Sacramento. How important is it that emergency services in cities and counties focus on potentially proactive services versus 911 services?
Such a great question. And so allow me to digress a little bit. As a forensic psychiatrist, there's something called the sequential intercept model, which is a complicated way of saying something very simple, which is there are all kinds of points where an individual suffering from schizophrenia can end up with criminal justice contact. And intercept 0 is when you're in the crisis and you call 911. Intercept 5 is when you're leaving prison and trying to reintegrate someone into the community. And the widely understood truth is the further upstream you can get in that intervention, the better it is for the patient, the better it is for public safety. And so what the CARE Act is designed to do is to be intercept 1 or 2 when the first responder's encountering someone who's got severe symptoms of schizophrenia, who's at risk for incarceration, homelessness, or death, or who is experiencing homelessness or repeated incarceration. That's the target population, are the individuals that we see on the street who are yelling at people who aren't there, who are unsheltered, who are untreated, who have repeated criminal justice contacts, cycling through the jails. Just a data point for you. Over a 5-year period of time, when individuals were coming into us, we were looking at their rap sheets and keeping track of previous arrests. And from like 2009-10 to 2014-15, the number of people we were admitting who'd been arrested 15 or more times increased from 16 to 46% in 5 years. So we have this group, small but very, very disadvantaged group of people who are, because of their untreated symptoms of their brain disease, experiencing homelessness and these repeated criminal justice contact. And with all that comes trauma and, all kinds of other the longer you go without treating your schizophrenia, you develop cognitive problems. So now you're getting more and more disorganized and unable to take care of yourself. That's the target population that we're trying to disrupt this cycle.
What do you think? I mean, implementation is coming on your end as a doctor, and our primary audience here are firefighter, paramedics, private ambulance, public ambulance, paramedics. What are probably the 2 or 3 most important things that we can do and need to know to use CARE Act to disrupt this cycle?
File petitions. There's no harm in filing a petition. You don't have to have a rock solid diagnosis to file a petition. You can file a petition and say, I've seen this gentleman 5 times in the last month. He's screaming. He's living in a very filthy, situation. I've seen him eating out of the dumpster. He's yelling at people who aren't there. He seems paranoid. File the petitions, and the judge will sort it out. The judge will take a look and see if there's any face value to that petition. So, and if there's not, it gets dismissed. So you're not going to do any harm just by you're really bringing someone to the attention of the care court in that case, for them to look into it and figure out if that person qualifies for care. So that's one thing. Another thing that your teams can do is coordinate with the people in the emergency department and the other people who are touching these individuals. Make a list of the 10 people in your community who are living in these situations, and work with your ED providers, your hospital social workers. Come up with a way to get these individuals prioritized. Care is very nuanced and it's very thoughtful, and so there's all kinds of confusion out there about what care does. The number one thing that the CARE Act does is it brings individuals to the front of the line for services, and it provides an opportunity for a civil court judge to make sure that person is getting those services. That's the purpose of the CARE Act. And people say, well, there's, not a lot of resources, and some of those things are true, and I don't dispute that. But you're moving someone to the front of the line who wasn't even in the line,
Right.
who didn't know there was a line, and who are experiencing the very worst
Nobody
outcomes.
even knew they were there.
No one even knows they were there. Exactly. We had a young woman come speak to our CARE Act stakeholder group a few months ago who had been a straight A student at the University of Southern California who developed schizophrenia in college, which is typically the age when individuals develop this disease. And she was homeless on the streets of LA. Starving, eating out of the trash can, experiencing this very thing. And she has since received help and she's in recovery and no longer symptomatic and graduated and so on and so forth. But she said no one ever approached her to help her.
Wow.
Not in I think it was a year and a half or 2 years she was living on the open street. And that's what care is for, so that first responder who sees her can say, hey, judge, this individual really needs some help. Can you ensure that happens for her? And that's the purpose of the CARE Act. And that's not very well understood.
You can be, even though you're a 911 provider, an engine company firefighter, truck company firefighter, paramedic, medic, paramedic, you can still be proactive. And what I heard, most departments have an EMS officer. Some of them, they're assigned to shifts and they oversee medic operations and resupply and do all the things that they do. And what I picked up on, Kate, with what you were saying was establish a relationship with your local emergency department, and bring forward the people that you know of.
Right.
And that kind of gets the conversation going, but it is going to be up to us as, I'll just put it quite frankly, the protectors of California.
Yes.
And the protectors of the people that have the least and that are the weakest among us.
That's right.
If we don't advocate for them, nobody's going to do it.
That's right.
And that's, I think, what I really want firefighters and paramedics that are listening to this to get to your medical director within your department, get to your county medical director, the ED docs and nurses that you have relationships with, start this conversation and be proactive in utilizing the CARE Act and breaking the cycle for people. Because if we don't do it, it's going to get done, but it's like you just said, it's going to be through the law enforcement side of the house, because I can just see it. Initially, I was thinking about, well, how does a person get arrested for this? And it's like, innocently enough, if you're out there, you're seeing things, you're believing things, you're having these conversations, and the next thing you know, somebody's close to you, you may push them, you may hit, whatever it is, it doesn't take much to be under arrest, and it can escalate from there. And I do think this is going to be super important for our partners in law enforcement. If they see and they know folks that they're going to all the time, make sure we know it.
Right.
So that together, what if we take 10 people off the street in Sacramento?
Right.
In each hospitals kind of have a first in area just like we do.
Right.
Sutter General, Sutter Memorial, Harbor, UCLA, all those places. What if we took 10 people from each of their kind of first in area off of the street? The difference doesn't start in the thousands.
Right.
It starts with a 1.
Right.
So, is there something that I missed that you want us to know as firefighters and paramedics in the street?
I would say, your stock and trade is saving lives. And, you have someone on the sidewalk who's having an MI, you can save that person's life. We have people on the sidewalk who are essentially having a brain attack, not a heart attack. And there's never been a tool for your first responders who are out there saving lives to do anything about it. But now there is. So please file those petitions, get those names in, organizing your local communities, take 10 people at a time. I think that's an amazing approach. I want to say one thing just so I'm comprehensive in the clinical aspects of what a care plan is. So a care plan is delivering stabilizing medication. And I explained how until now, someone had to be dangerous before they could get treatment. And one of the reasons for that is if you lack insight, you don't have medical decision-making capacity. And it's impossible to get informed consent from someone who lacks medical decision-making capacity. So the CARE Act does have the ability for the judge to order a medication order. That does not mean forcing medication. That means overcoming the barrier of trying to get informed consent from someone who lacks medical decision-making capacity. And that's getting painted as something, this is involuntary treatment. No, that medication order is just there so that you can overcome the barrier of trying to do something impossible.
It's part of a treatment program.
It's part of the treatment.
That as asinine as it sounds, was not available prior to this.
Right.
I want to touch on that because it's important because I have heard it. This is involuntary conservatorship. This is taking over a person's rights. And that's furthest from the truth.
That's right.
It is putting a person in a position to get their illness treated.
That's right.
And be in a position to make good, informed decisions for themselves.
That's right.
And I'm going to guess that when people are going to have, there's all degrees of schizophrenia, and it's starting to it's progressed very deeply. But I'm going to guess that as a person gets treated, they're going to come to a point in their life where they're able to make a decision on their own behalf.
Absolutely.
That's not never going to happen. I mean, there's probably some people that are pretty sick and it could take a long time, but to provide people with medical help that don't have the ability to ask for it and get them into a place to recognize that they need help. That's what we're talking about here. It
exactly
is not,
right.
We're not forcing anybody to do anything. It's kind of like removing some of the requirements so you can put a person in a position to be successful. That's why I want our firefighters to look at this. This is about being a part of helping get people off the street and back into a productive life. And that can be very simple to very complex. I don't know, but we've never had this opportunity before.
That's right. And, I'm a student of mental health history, and we've had a lot of noble efforts over the last 250 years of our existence. When they built these big asylums, they built them out of humanitarian impulses, but they got overcrowded because there was no accountability and implementation. Deinstitutionalization was well intentioned, but it failed at the level of accountability and implementation. And so our legislature, our governor has given us an opportunity, the first opportunity in my career, to do something about this
It's a pretty
problem.
profound statement. How long have you been a doctor?
20 plus years.
The
Yeah.
first opportunity in your career to do something positive about a situation that is, if you go to any fire station in this state and you ask, give me your top 2 or 3 issues you deal with, and one of the first ones they'll say, homelessness, and that does mean people suffering from schizophrenia, mental, all those issues.
That's right.
That's a pretty big statement. This is the first time in my career.
First time in my lifetime, really.
Lifetime.
Yeah. But it's going to boil down, just like every reform that hasn't worked in this country, it is going to boil down to accountability and implementation. And that's where we need the help from the people on the ground who are interfacing with these people every day. We need your help.
And that's why I'm doing this. We have a role to play here. And we pick up that mantle, we be part of that team, we be part of breaking that cycle, and then we work with our partners within the hospital system and then with the regulators to make sure that we're all doing our job and we're all functioning and making this piece of legislative reform work like it's supposed to for the first time in a lifetime.
That's right.
Kate, thank you so much for being here today. I want to close and just, again, Dr. Warburton, I want to thank you for joining me today on the Firewire, providing insight into how Care Court is going to make positive differences in our communities. You've been a champion of mental health and finding solutions that work. And I just thank you for that, and thank you for that lifetime of commitment. And we're going to do our part as firefighters to help break this cycle. With that, I'm Brian Rice. I'm the president of California Professional Firefighters. I want to thank everybody for tuning in to the Firewire. Until next time, thank you.